just want to take just a couple minutes to see if you can kind of just walk us through these cases, your thought process, and just kind of just touch on the key aspects of the case that made that case successful.
Yeah, so I don't remember the patient's exact age, but this is somebody in their 50s who has sort of basicervical slash transcervical fracture here that is varus displaced, right? So you can see that varus displacement in their fracture, and they're on the fracture table already. So I think we don't really see the lateral view before traction, but really, I mean, it's hard to say that you shouldn't fix this particular fracture, right? Because if you look at it, you can clearly see the anterior and posterior aspects of the neck on that lateral X-ray. We're able to get a really nice picture, and it's anatomically reduced. We've pulled it out of varus in that middle image there. And there's still a little displacement there, but I'm willing to leave that little bit of displacement right there because I know that I can compress that with my implant and I can get that squeezed down. I'd rather have a little bit of opening there and see my neck shaft angle and valgus than squeeze that down before surgery and have a varus malreduction. So in general, we were able to, I think, get a pretty nice reduction in its traction.
And then they say on the laterals that you kind of want that kind of that S, of the necks, like kind of that S
Right.
shape, I guess, to be recreated, and that kind of will show you that you have a pretty good reduction here. And I think we have a continuation of the case.
And
To kind of
actually,
walk us through.
one quick second, because I actually think this is something that even for myself, I remember even as an intern, just recognizing where was anterior and where's posterior
Yeah.
when you're looking at these laterals.
Yep.
Can we point that out too? Because honestly, I just saw someone get this wrong, and it's definitely like worthwhile to mention it.
So to me, somebody taught me a long time ago that the anterior is where the air is.
Yeah,
So
I like that.
the left side of that image is your anterior neck. And then the most prominent thing in the posterior aspect of the femur is the lesser trochanter. So where the lesser trochanter is the posterior aspect of your femoral neck. So that's excellent thing to point out when you're a young resident and you're trying to figure out what side's up. That air is where your anterior neck is.
It's a good way to remember it.
Yep, I like that. And then so kind of walk us through this reduction or this sequence of events here.
Yeah, so unfortunately, I don't have a lateral view of this. I wish I did. But I saved these three images. This is the Synthes femoral neck system. Again, they're not paying me anything to say anything nice about this system. But you can see the compression that this system provides. So on the far left image, you can still see that gap. And then in the middle, we've compressed it a little bit. And then in the far right image, you can see where we've pretty much completely reduced that fracture down on that medial cortex. So the device is pretty nice that it allows that sort of compression. Can you get that with 3 screws? Yeah, probably. You can do that with a nice partially threaded screw. But this implant, I think in good bone is a nice option to use for femoral neck fractures.
Like it. I think that was a great case there, showing us that kind of that compression and showing us how you got that reduction and getting the neck out of varus. Can you kind of show us through what this image here is showing, or what you're trying to show us with this shot?
So this is a different femoral neck fracture, and we've chosen to fix it with cannulated screws, and we're looking at that nice spread of our pins that we've placed. So the posterior neck is the left side of the screen, and the anterior neck is the right side of the screen. And you can see how we have diverging screws or diverging pins at this point that really ride those anterior and posterior cortices. So you cannot do this with any device that is supposed to provide you with spacing of your screws. Some people might disagree with me, but I don't think you can get this spread. And this is what you're looking at. And if you have the AP view, those anterior and posterior screws, yeah, you can see you're pointing out they're not penetrating the femoral head.
Correct.
So that's important. You want to make sure that you're not penetrating the femoral head or potentially causing a risk for AVN.
Excellent.
If you look at this on the AP view, those anterior posterior pins are not going to be, they're not perfect. And I don't think it matters. I think that this spread is the most important thing. So.
Okay. Perfect. Great. And then this is kind of, if you want to kind of walk us through this, this other case here.
To me, this case is a bit of a tweener, right? This is, it looks like it's a little bit impacted. When you look at the lateral view, we're lucky to have a nice lateral view here, but you see that there's comminution along the anterior neck. So the right side of the screen is that anterior neck, and you see that comminution there. To me, it makes me a little bit nervous. It makes me want to talk to the patient and want to understand who they are and what they do, and give them the option and say, hey, listen, you can get fixation for this fracture. It could potentially fall apart. If it does, you might require another surgery. But really sort of, you can see on that right side, the two images on the right are our traction views before, prepping and draping, and it's nicely reduced. That calcar is nicely recreated there, and even with considering the anterior comminution, that lines up okay. The head is not posteriorly malreduced on the far right image. So the posterior segment there where the lesser trochanter is, we've been able to create some more of that anteversion in the head. And so this is, to me, this is reduced enough that you can trial fixation. And we've talked to the patient and we said, if we can't reduce it, you're getting a hemiarthroplasty, but we'll put you on the table and try it. And turns out we were able to make it look okay. And here's an example of, if you look at those screws, so we used one partially threaded screw inferior to compress the inferior neck. And then we've used fully threaded screws in the superior screws to prevent over compression of that anterior fragment. So the far right images are follow-up images, and I think it moved a little bit, but it certainly didn't completely fall apart. It was fixed enough that it was able to hang on and heal, and I think that getting the screws in the right position is helpful for that.
Yeah, I think those are both great cases, and we have a third one here.
So this is displaced. This is a good example of the completely displaced femoral neck fracture. There's a giant gap sort of on that lateral femoral neck there, and then the lateral image doesn't project well. Sorry, I didn't send you a good picture.
No, it's no worries.
But it's fallen off completely, right? The neck is the neck shaft angle is severe varus. And on the lateral, it doesn't appear to be anywhere in the right neighborhood. So this to me is an arthroplasty case for sure. It's talking to patients about it's learning about them and figuring out how old they are and how active they are and what their other medical comorbidities are. And then we can do some kind of arthroplasty procedure for
Yeah.
them.
Kind of looks like this is the head here, kind of an outline,
Yeah, I think so.
and you don't have that kind of S shape that we were looking for.
Yeah, it's just completely collapsed. So
Yeah.
one thing I think that, I guess for completeness sake, we should mention that in a severely moribund patient that that is just going to lay in bed and truly never, they get rolled for hygiene and that's it. The other option to think about is resection arthroplasty or a girdle stone procedure. That is, if we want to just say that we've talked about all the options, it's something that you can consider sometimes for patients, or maybe in a patient that has had fixation or had an arthroplasty and they've had an infection issue or something like that, and they need another procedure for source control, but don't necessarily need an implant. That's always a consideration. So, for completeness sake.
There it is. I think this was a great way to end the show.